Hello everyone, hope you're all doing good. In this video, we are going to discuss about one of the important incisions that is given during natural labor. Yes? Yes, we are going to discuss about episiotomy, right? So what is episiotomy? Episiotomy is a surgically planned incision on the perineum and the posterior vaginal wall during the second stage of labor. Okay. So this is the definition, and also know that episiotomy is also known as perineotomy. Perineotomy, because the incision is given in the perineum. Okay. Now we'll see what are the objectives. Why do we give episiotomy? Episiotomy is given to enlarge the vaginal introitus so as to facilitate safe and fast delivery of fetus. We also need to minimize the overstretching and rupturing of the perineal muscles and fascia. Okay, right. So this will also reduce the stress and strain on the fetal head as well. Okay, so all these are objectives of giving episiotomy. Now we'll see when to give episiotomy. So timing of giving episiotomy, it is usually given when there is crowning. Okay, so that is when around 3 to 4 centimeter of fetal head is visible. Okay, so during this time you will be able to see bulging of the perineum, as well as the perineum will be thinned out. Okay, and remember, episiotomy should be ideally given during contraction. Okay, so this is the ideal timing of episiotomy. Then, suppose if you are giving episiotomy for forceps delivery, you have to give episiotomy just before the application of the blades. Okay, yes. Suppose if it is done early, then via the episiotomy wound there will be increased bleeding and there will be increased blood loss, and when it is done late, it fails to prevent the lacerations. Okay. Hope you would have understood up to now. Now, we will see the indications in which you have to give episiotomy. See, remember one point, episiotomy is not necessarily given in all natural labor according to the guidelines. Okay. So, indications of giving episiotomy: when she is a elderly primigravida. Okay. So, what happens here is there can be any chance of arrest or delay in descent of the fetal part, okay, of the fetal presenting part we can say. And whenever you are anticipating perineal tear, okay, for example, when there is a big baby above 4 kg, then there is a phase 2 pubis delivery anticipated, or malpresentation like breech presentation, shoulder dystocia, persistent occipito-posterior position. Also, as we have already seen, it is given in instrumental delivery. What are be the instrument we use. Okay, either it can be a forceps or vacuum. Okay, then suppose there was a history of previous perineal surgery in the women. Okay, like if she had previous pelvic floor repair or perineal reconstructive surgery. Clear? So, these are the indications ideally when you have to give episiotomy. So, once again we will revise this. Episiotomy indications include elderly primary gravida when you expect arrest of descent or delay in descent due to repeating once again. So, once again we will discuss these indications, which is very important for you. Now, once again we will discuss these indications again. So, first point is this elderly primary gravida where you expect a delay or arrest of descent of the placentic part. Then other conditions where you expect perineal lacerations like BBAB 4 kg, then forceps delivery breech presentation, shoulder dystocia, persistent occipital posterior portion, and then instrumental delivery like forceps or vacuum, then previous perineal surgery like pelvic floor repair or perineal reconstructive surgery. Clear? Right. Now, we will see the advantages of giving episiotomy. So, advantages include maternal advantages and fetal advantages. For the mother, a clear and controlled incision if you give, then this is easy to repair as well as healing is also better. Okay? And then there is reduction in duration of the second stage as well, right? Then we can prevent trauma to the muscles. Now, what are the fetal advantages? For the fetus, it minimizes the intracranial injuries. Okay, minimizes the intracranial injuries, especially in case of premature babies and after coming head. Okay, so that's it. Now, we will see what are the types of episiotomy you can give. Okay, so types of episiotomy. We can have a mediolateral episiotomy, which will be 60% of the midline. Okay. So, this incision is made downwards and outwards from the foreshead either to the right or left. Then it is directed diagonally but in a straight line. Okay, directly but in a straight line that will be running 2.5 centimeter away from the anus. Okay, so that will be approximately, it will be in the midline between the anus and ischial tuberosity. Clear? Yes. Now, we will see the second type of episiotomy you can give, median episiotomy. So, this commences from the center of the foreshead itself, okay, center of the foreshead, and this extends posteriorly along the midline for about 2.5 centimeter again, right? And then we have the lateral episiotomy. This incision starts 1 centimeter away from the center of the foreshead and this extends laterally as well. Okay, but while giving a lateral episiotomy, you have to understand that there are so many disadvantages, including damage to the Bartholin's duct. Okay, so there can be damage to Bartholin's duct, which can be a drawback. So this is not permitted in any time. Okay, and fourth type of episiotomy is a J-shaped episiotomy, where the incision will begin in the center of foreshead and it is directed posteriorly along the midline for about 1.5 centimeters. Okay, then it will be directed downwards and outwards. Okay, just like a jetter J. Okay, so it can be along right side or left side, so 5 o'clock or 7 o'clock position, so as to avoid the anal sphincter. And what is the disadvantage here is apposition is not perfect and sometimes the wound tends to appear puckered. Okay, so we are not preferring this incision. So this is the episiotomy scissors we use. Okay, so this is an angulated scissors. Okay, so this is a unique type of scissor that we use in obstetrics and gynecology, and you will be able to identify it easily. Only thing you have to see is it is angulated, right? So these are the types of episiotomy we are going to see. So in the types of episiotomy, if you see, number 1 is the median episiotomy, where we will be starting from the foreshead and we will be passing downwards towards the anus, right? And type 2 episiotomy is the mediolateral episiotomy, where will be passing in a straight line only, but it is a diagonal line. Okay, and that will be passing between the anal sphincter and say ischial tuberosities, midway between the anus and the ischial tuberosities, right? And the third type is the transverse or the lateral episiotomy. So it is number 3. Okay, so this is not exactly lateral, but even then it is somewhat distant from the foreshead, so we are kind of considering it to be a transverse or a lateral incision. Definitely we are not taking this incision because there is damage to the Bartholin's glands, right? And then finally we have the type 4 incision or the J-shaped episiotomy, where we will be directing straightly like a median episiotomy, then we will be taking a turn like just like this. Okay, so if you see, this looks like a letter J, right? So why we are taking this turn means to avoid the anal sphincter. But the only episiotomy that is preferred to give in routine practice is mediolateral episiotomy, right? Now we will see what are the steps of episiotomy. So episiotomy steps. So step 1, that is preliminaries. Now we will see what are the steps of episiotomy. So episiotomy, number 1, the perineum is thoroughly cleaned with antiseptic, say povidone iodine solution, and it is draped properly. Okay. Then what we do, the local anesthesia is given in the perineum in the line proposed of incision. Okay, will be infiltrating 1% of solution of 10 ml of lignocaine, right? And then will be giving the incision. So what are the structures cut during episiotomy? Okay, so this is one of the important aspect of this whole content. So the structures cut during episiotomy include, say while giving incision, we are placing 2 fingers inside the vagina. Okay, so here you see 2 fingers inside the vagina, that is present between the presenting part and the posterior vaginal wall, right? Now if you see, the two blades of the scissors, one blade is between the foreshead and the two fingers, whereas the other blade is outside on the perineal skin. Okay, and the incision should be made during the height of uterine contraction. Okay, so that you shouldn't forget, height of uterine contraction, with an accurate idea of the extent of incision. And remember that the incision should be given during the height of uterine contraction, because the accurate idea of the extent of incision you can get when there is maximum stretching up of the perineum, right? You should make a deliberate cut that is extending from the center of the foreshead and either towards the right or left. Okay, so if you are doing it towards your right, it will be called as right mediolateral episiotomy, and if you are doing it towards your left, it will be called as left mediolateral episiotomy. Clear? Right. Now, so structures cut during episiotomy include posterior vaginal wall, the superficial and deep transverse perineal muscles, also other muscles like bulbospongiosus and part of levator ani. Then the fascia that is covering all these muscles, and you have, and then the transverse perineal branches of pudendal vessels and nerves. And finally, we will be cutting through the subcutaneous tissue and skin. Clear? So, if you see this picture, you will be able to understand the muscles that are cut in episiotomy. So, these are the muscles that are cut in episiotomy. So, we will be making a cut from the posterior foreshead just like this, right? So, the muscles cut include bulbocavernosus, superficial transverse perineal muscles and deep transverse perineal muscles, and even levator ani, because you see the extension is coming into the levator ani as well, right? But definitely ischiocavernosus which is present above, it is not cut. Okay, so that one you have to understand, right? Okay, now we have given an episiotomy and delivered the baby as well. Now, what are the repairing steps in episiotomy? So, repair steps include the patient should be in a lithotomy position, a good light source should be there, it should be cleansed with antiseptic solution again after delivery. Okay. Then please do check for blood clots or any lacerations that are present in the vagina. The patient has to be draped properly and repair should be done under strict aseptic precautions. If repair field is oozing out of blood, okay, then you can keep a sterile vaginal pack also, okay, that can be placed high up to stop intervening of the blood in the suturing site, right? Okay. Now, we will see what are the repair layers you will get. Okay. So, while repairing, you should follow certain rules. Okay. You should be cautious enough to attain perfect hemostasis. Then, you have to obliterate the dead space. And suturing should be done without tension. Okay. So, how you will be suturing? Just in the reverse order, right? You have to start from inside and you have to come outside. So, you will be suturing the vaginal mucosa and submucosal tissues first. Yes, this will be followed by suturing up of the perineal muscles and finally we will be suturing the skin and subcutaneous tissue as well. Clear? Right. So, if you have an episiotomy wound like this, okay, so this is how the episiotomy wound will appear, okay, just like a triangular shape, okay. So, you have to start your suture right above the apex, okay. So, the type of suturing that is done for mucosa is, you will be doing a continuous suture, and for the muscles, we give an interrupted suture, and for the skin, we give a box suture or mattress suture, okay. Sometimes what they say is, in some textbooks how it is given is, you have to start from the mucosa that is above the apex and you have to continue all throughout the mucosa, muscles and perineal skin, and then you have to finish the suturing, right. So, this is for beginners actually. So, that is also another method that is mentioned in the textbooks, right. Okay. Now, what are the complications we can expect with episiotomy wound? So, with episiotomy wound, we can expect immediate complications like there can be extension of the incision over rectum, yes, that is possible. Then there can be formation of vulval hematoma, and there can be chances of infection as well. So, when infection is there, there will be throbbing pain on the perineum, then there can be fever, that is rise in temperature. Wound area will appear moist, swollen, and it will appear with redness. And finally, you can even have offensive discharge as well. Clear? Okay. Now, how we are going to manage this? So, treatment, whenever there is a collection, you have to first plan drainage of hematoma or pus, whatever, okay. Local dressing with antibiotic can be given. See, this is not necessarily given for all episiotomy wounds. Whenever you have pus or vulval hematoma that has been evacuated, in that time you can give dressing, okay. And sometimes if there is severe edema and pain, you can even give a maxil dressing. Definitely when there is an infection, you have to start them on IV antibiotics, okay. And don't forget to check about the rectovaginal fistula if it has happened or not, okay. And remote complications what you can have with episiotomy may include there can be dyspareunia or chance of perineal lacerations in subsequent labor, and then there can be scar endometriosis which can arise in the episiotomy scar even, okay. So, this is all about episiotomy. So, I hope this video has helped you. Until we meet in the next video, take care, happy learning and bye bye.